Welcome to Neurology, Disease Deep Dive. In this series, Dr. Derek Robertson, Director of the Multiple Sclerosis Division at the University of Southern Florida, and from the New York University Grossman School of Medicine Comprehensive MS Care Center, discusses multiple aspects of NMOSD. Dr. Robertson is talking with us today on behalf of Horizon Therapeutics, which is compensating him for his services and is sponsoring this podcast. In this episode, Dr. Robertson presents an overview of NMOSD treatment, including goals, triggers, and considerations for switching therapies.
Hello, welcome to our third and final podcast in this series on treating NMOSD. I'm Wendy Terry, publisher with Practical Neurology, and I'm here with Dr. Derek Robertson. So Dr. Robertson, I'd just like to start this last episode off on talking about the treatment options for NMOSD. So we've covered the disease process, we've covered monitoring patients. Now let's talk about what there is to actually treat patients with NMOSD.
Well, hello, Wendy, and a pleasure to be back with you. Selfishly, I'm the most excited about this part because for years we did not have FDA-approved treatments for patients that had seropositive NMOSD, and that now, thankfully, over the last few years anyway, we've had the ability to give patients some hope with relapse prevention to help with their condition. How we approach treatment for NMOSD patients, again, we'll talk maybe specifically about seropositive patients, is we look at it as two tracks. When we're first diagnosing a patient, the much more sense of urgency problem is acute treatment for the clinical syndrome they're experiencing. Say it's optic neuritis or transverse myelitis. We want that to be accurately diagnosed, treated in the best way possible to then allow them the chance to get as much recovery as possible. And then maintenance therapy is the next step. So once we get patients in that cooling off period, they've had an attack, we're inheriting them into our clinical practice and going to plan on following them long term. Maintenance therapy with one of those three FDA-approved treatments for seropositive NMOSD is kind of the next treatment phase.
And what are your treatment goals when you're choosing one of these three FDA-approved therapies?
A great question. So the medicines themselves, there's again three FDA-approved treatments for seropositive NMOSD, have entirely different mechanisms of action. Their risk-benefit profiles are different, but the treatment goals are all the same. And so I think there's at least a commonality when we're talking to patients and we're helping them navigate which treatment option maybe is best for their scenario. It doesn't change what we hope the medicine, or frankly, what we want, what we expect the medication to do, which is to put them into a relapse remission state. We do not want patients to have relapses. Any study that's looked at this, there's a decent consensus that patients with NMOSD experience disability increase nearly entirely from relapses. And so the converse of that is also true, that if we can prevent relapses, we will save that patient a whole lot of future disability that they would have experienced from having those attacks that we're now preventing with appropriate maintenance and immune-based therapy. So that's the treatment goal, is to put patients into a kind of a sustained remission state, maybe is the best way to say it, where we're preventing future relapses and thus future disability from occurring.
Great. So those goals are very easily understood. How do you then choose or select which treatment you're going to prescribe or administer?
Yeah, it's the right question to ask when we think about long-term management, but maybe if it's okay, I'll back up and actually talk about acute treatment first, because that's kind of the first decision point that we have with our patients to get them the best, to have them have the best chance to have the least amount of disability from the bad thing that's already happening to them. So when a patient lands in our emergency room, maybe they say already have an established diagnosis of NMOSD and now they're having a relapse. Our kind of treatment algorithm is to start them on high-dose steroids, usually intravenously, as fast as possible to start to blunt some of that immune-based inflammation. and then have a very low threshold if they're not having a good steroid response at blunting that inflammation, to start plasmapheresis. So we don't plan to do plasmapheresis on every single patient that has a relapse, but we have the capacity to do it, and we have a pretty low threshold to start it. At our center, our branch point, when we are bringing patients into the hospital and we're treating them for an NMOSD attack, is to give them 2 days of IV steroids, and then by day 3, if they're not already plateauing, or even better, starting to have some uptick in recovery of the symptoms that were driving them to the hospital, we're starting the process for plasmapheresis on day 3, and then deciding whether or not to continue both beyond that, or to just transition to just plasmapheresis alone. Plasmapheresis is a fantastic treatment for the acute management of relapse for NMOSD, but it has a decent amount of risk-benefit conversation to have with patients. And so it's not the standard, everybody gets it if they're having a relapse, but we do need to keep it as a very close plan B for the patients that aren't getting good benefit from, in our case, IV steroid treatment within those first couple of days. That's kind of the first question, is how do we help patients have the least amount of disability from the bad thing that's already happening, their acute relapse? Then the second question, which is way more nuanced, is how do we decide between the 3, for seropositive patients, between the 3 FDA-approved treatments for seropositive NMOSD? And what we utilize is their mechanism of action. If somebody's already tried one mechanism of action of therapy and it didn't work, they've had a relapse despite good compliance, tolerability of the medication, then that makes a decision easy. Then we narrow down to those other 2 different mechanism of action therapies, and then weigh the pros and cons. The harder one is when they're treatment naive, so they haven't had any of the medications yet, and they're a brand new diagnosis, let's say. So then we just really utilize what we learned from the 3 different medications from their individual clinical trials to help guide those treatment decisions, what the risks, what the benefits are, the route of administration, the frequency of timing of treatment is different between all 3 FDA-approved treatments. And we use that as our decision maker to try to make as individualized of a patient decision for the treatment choice as possible.
And if patients ask you about possible side effects of these treatments, what's your typical response? What do those patients need to know?
Yeah, so the side effects, again, it's really difficult in these short formats to unpack this completely, but it's okay. I think it's the right question to try to tackle, in that the side effect potential amongst the 3 different treatments is incredibly different. If somebody's having a side effect for one, it doesn't automatically mean they're going to have it for the other 2. And in fact, there is some commonality among side effects, but there's also some uniqueness between the 3, in what labs you have to monitor, what labs you have to obtain prior to starting on treatments, all totally different. There can be medication interactions if somebody's already on certain types of medications. So all of that kind of goes into the decision-making process.
And you already touched on this, but what do patients need to know before they start treatment? Like if they're scheduled to have a vaccine, is that something that's, going to have to be, the date going to have to be altered? Like what are those things that they need to know beforehand?
So the uniqueness is there for all 3 therapies. Sorry to sound like a broken record, but it really is. All of the, I think it's fair to say that despite their uniqueness, there is kind of a clear path forward on laboratory monitoring requirements on each of the individual therapies, necessary labs to obtain prior to initiation of therapy. There's some nuanced differences between things like vaccination prior to and then during the course of utilizing the different immune-based therapies, the 3 that we're kind of referring to that are FDA approved. But all of that goes into the decision-making process. Since
you hit on decision-making process, what is that decision-making process when you decide to switch therapies? So what are the triggers? How is that decision made?
The first trigger when we're deciding amongst a treatment therapy is probably the easiest scenario to lay out would be if somebody's failing treatment. and probably maybe put better, the medication is failing the patient. So that mechanism of action drug isn't working for the patient. Good compliance, they're tolerating the therapy. Say they're on an IL-6 monoclonal antibody. That's one of our treatment options. If they're on that therapy and then they have a relapse, then we would talk about the other two mechanism of action of drug. One is a B-cell depleting monoclonal antibody, and then the other is a complement blocker monoclonal antibody. And the hope would be is that the use of one of those other two with a different mechanism of action, one or the other, would be hopefully a better option to put them back into that remission state that we want to see. But that scenario can play out in the other ways. So if they have a relapse on the complement blocker monoclonal antibody, then one of the other two should be considered. So that's kind of the first question, is kind of utilizing mechanism of action response as a trigger for a treatment switch if the medication fails the patient and they have one of those 6 core clinical syndrome relapses that we talked about. Where it gets a little harder is with non-efficacy reasons maybe to switch. And so each of the therapies can have tolerability related issues. Still, sometimes we see patients that are placed on non-FDA approved treatments. And then if it doesn't work, or if a patient is having tolerability issues with that, that is the other kind of decision point that can pop up as an indicator maybe to consider a treatment switch. So if they're having injection site tolerability with, say, the IL-6 medication, if they're having infusion-related reactions with the other two therapies that are FDA approved, so the B-cell depleting medication or the complement blocker medication, if they're having, those are both infusions, so if they're having infusion-related reactions with one of those, maybe we would consider the others. Those are kind of the triggers to then talk to patients about treatment changes.
Dr. Robertson, can we talk a little bit about polymorphism in NMOSD? What exactly is that?
So this is gaining a little bit of traction. And again, to my point earlier that we made in both previous episodes, is that we want to do as good of a job as possible on as narrow of a focus area possible of doing individualized medicine. We're not able to do it on a per patient basis yet, but this idea behind polymorphisms is starting to bubble up as a thing that we should at least know about as it relates to the treatment of NMOSD patients. There is this concept of genetic polymorphism as it relates to the immune system, potentially the immune system response amongst different therapies. There's at least one study that I can think of that has kind of shaped my opinion on this. So there was a study in Asia, it was published, I believe, somewhere in the neighborhood of 8 years ago, that looked at rituximab, so a B-cell, anti-CD20 B-cell monoclonal antibody, and its treatment response in patients with NMOSD. And it looked at it through the lens of genetic polymorphisms on a very specific part of the immunoglobulin that helps potentially gauge treatment response. There's a binding, a receptor portion of immunoglobulins that we think target the disease of NMOSD. And there's 2 different alleles that lead to the binding affinity. So how well in this case, the immunoglobulin, how well it can bind to the B cell and therefore maybe have a treatment response. There's 2 alleles that do that. There's a high binding one called valine, and then there's a lower affinity and perhaps maybe inferior binding genetic variation allele called phenylalanine. And so when patients have valine alleles, then they have tighter binding, and the treatment response, perhaps on B-cell binding capabilities of the immune system, were decently, if not significantly, well intact. If somebody they were low affinity binding, so they had more of the phenylalanine allele structures, then the B-cell response wasn't as good with rituximab. So we've used rituximab as an off-label medication. It is not one of the FDA-approved treatments for seropositive NMOSD for years, but knowing that there's a very real percent of patients that could have this genetic variation and that it might affect the ability of rituximab to work as well for their condition has led us in our practice to not utilize rituximab as much anymore. And again, we've used it for years because B-cell depletion clearly can help patients that have NMOSD. But now there's this newer option that's an anti-CD19 approach, monoclonal antibody, called inebilizumab. And so that medication, when genetic polymorphism studies have been done, asking that same type of question. So we know that there's an allele difference that can happen. Valine is better. It allows for that tighter binding. Phenylalanine, again, you can't help it if it's your genetics and if you have that predisposition. And the question was asked in the clinical studies done with inebilizumab, if there was that same polymorphism difference in binding affinity, and thankfully there was not. And so whether that translates to a significant benefit of one therapy over the other, I'm unsure of the answer of that, but I do know, broadly speaking, I would prefer to target therapies as best as possible. And if one of the variables we can control is utilizing a therapy that is FDA approved, that thankfully doesn't seem to have an effect on binding affinity potential from those polymorphisms, that's why in our center we've trended toward using A, FDA-approved treatments for our patients, and B, perhaps maybe that personalized approach and kind of excluding the polymorphism difference that could happen with rituximab use.
That was a phenomenal explanation so thank you for that. We'll wrap up here with just a couple of last questions. How has your practice changed since these newer NMOSD treatments have emerged?
Oh, that's such a great question. So I would say that having taken care of NMOSD patients for years, I was kind of getting used to, and I didn't want to, but I was getting used to the fact that we'd had good but not great treatment options, and that patients, if we can put them into remission for years, and then if they had a setback, we'll look at all those relapses we probably prevented by keeping them in remission for even a few years. I think our treatment bar is much higher now, and we expect so much more really out of all three approved therapies. FDA approved therapies absolutely can work for patients and have relapse prevention ability, put them into those sustained remissions that we want to see. So I think the ask now is much higher, and that we have a lower tolerance in our practice for letting patients have relapses, even if it's a mild relapse, and being okay with that. We would encourage good compliance to medications. We would consider a treatment response to be permanent remission, and if not, really strongly have a conversation with patients and perhaps be encouraging of a treatment change to one of those different mechanism action drugs.
And then finally, what are you looking forward to as it pertains to the treatment of your NMOSD patients?
Yeah, so for NMOSD, I would say also for our MS patients as well, is we really need to see remyelinating agents. And there's been trials and treatment approaches that clearly seem to work and just haven't translated to working in human-based studies. I would like to see more NMOSD trials around remyelinating agents. And there's a bunch that are in preclinical development that I think I would like to see more targeted approaches for rare diseases, NMOSD being there as something that we look at. Right now, remyelinating agent approaches have targeted on the more common central nervous system autoimmune disease, on MS, and unfortunately they have not worked. I would like to see there be a renewed effort to not forget about NMOSD patients, and that when that destructive pathologies occurred, could remyelinating agents potentially help them? That what I would love to see move forward as kind of the next way to try to help our patients, is hopefully to promote some degree of recovery.
Dr. Robertson, it has truly been a pleasure working with you on this series. Thank you so much for your time and your expertise, and hopefully we'll be able to work again together in the future.
Sounds great to me, Wendy. Thanks again.
Thank you to Dr. Derek Robertson for sharing his knowledge with our listeners in this episode of Neurology Disease Deep Dive. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the neurology field. Neurology Disease Deep Dive is brought to you by the editors of Practical Neurology and sponsored by Horizon Therapeutics.